Good morning, everyone. I would like to welcome everyone for this amazing talk on the innovations in parathyroid surgery and preoperative localization technique. First of all, I would like to thank all the organizing committee, especially Professor Talat Wasim, who gave me this opportunity to become a part of 8 international conference, which is currently going in Shalimar Medical and Dental College. I'm Sherjeel Paul. I am a surgeon with a special interest in endocrine surgery. Cork University Hospital is level 4 tertiary care hospital, and in my unit we have the highest number of parathyroid surgery done in Republic of Ireland. I have no conflict of interest to disclose. Now, we all know primary hyperparathyroidism is a common and a very debilitating endocrine disorder for which surgery is the only curative treatment. I can tell that in UK and Ireland, it's a diagnosis which is very underestimated. Even though what the numbers we have is that is affecting less than 1% of the general population in UK and Ireland. Localization of the hyperfunctioning gland is extremely crucial for guiding the surgical management, and I'm going to discuss that briefly shortly. Among the diagnosis of primary hyperparathyroidism, approximately 85% of all the cases are secondary to a single gland disease. We all know parathyroid can be extremely unpredictable because of its embryological origin, but in a constant anatomical understanding, the foreglands, the upper glands, there seems to be more constant. They are more posterior to the thyroid gland, whereas the lower parathyroid glands, there seems to be a bit more vague and unpredictable. But there are kind of algorithms and prediction models. If you can follow them, then the possibility of a successful surgical outcomes is pretty high. The most important factor in parathyroid surgery is to achieve the cure in these patients. In order to understand the preoperative localization, the pathophysiology, and the mechanism by which we are going to understand how these glands are lateralized and localized, it's important to understand their histological significance. Now, the two important cells, chief cells, that are the most abundant in the parathyroid glands, which produce and secrete the parathyroid hormone, and there are occipital cells, which are rich in the mitochondria. And this is the principle behind the radiological localization, that the system EB or the technetium, it binds to these cells and it has an affinity towards these cells because of more numbers of mitochondria, and they are metabolically active. We'll touch that shortly. Now, a little bit of the pathophysiology. As I said, 80% they are single gland adenoma, and the rest are 15 to 20% multi-gland disease. There could be a possibility of 2 adenomas in one patient, and extremely rare parathyroid carcinoma. But also we embark on the other pathological variants which are secondary hyperparathyroidism or tertiary hyperparathyroidism. And more importantly, we need to understand, but it's not an adenomatous disease, it's a four-gland hyperplasia, and preoperative localization and the surgical management is very specific and tailored according to their needs. Now, before the surgery, localization is very imperative in order to achieve the cure in these patients and in order to increase the success, because the most commonest problem or complication dealing with parathyroid disorders is failure to achieve the cure. And by understanding the anatomy and localization, we are going to minimize this problem. By far more importantly, in a very specialist center, ultrasound is the first line of investigation. But because of its miniature size and its relationship with the local regional important structure, it can be extremely difficult to identify the parathyroid glands by the ultrasound. That's why we often get the help by getting scintigraphy. Now, I'm going to talk in detail about dual phase SPECT scan and dual isotope scan. In my unit, I personally like dual isotope scan, and we have recently published on a national registry that dual isotope scan is far better and superior when it comes to preoperative localization in parathyroid gland disease. 4D CT and 4D MRI, they are also investigation present, but they are not as sensitive and as specific. Choline PET CT, it's a rare radiological investigation, but in the centers where they have it, it helps in extremely difficult and redo cases as well. Now, bear that in mind. All these radiological investigations, they are not for diagnosis making. Primary hyperparathyroidism is a biochemical diagnosis. It's done on a clinical basis. The radiological investigation, they only utilize for the purpose of lateralization and localization. That's not only going to achieve the target, but it will also allow a surgeon to perform a very focused, minimally invasive operation. Now, just briefly, I'm going to touch on few investigations. On ultrasound, parathyroid, if you're very lucky, you can identify, and that appears as an hypoechoic or anechoic nodule. Of course, for the superior parathyroid, they're more posterior dorsal gland, whereas the lower parathyroids, they are attached at the lower pole, or they could be posterior, lateral to the lower pole, or they can be found in the thyrothymic ligament. The limitation with the ultrasound scan is that one may not be able to identify if the parathyroid gland is beyond the neck. Ultrasound scan in my unit, they are being done on all of the patients coming in with the diagnosis of primary hyperparathyroidism, but the intention is not to identify the parathyroid gland, but to identify a concomitant thyroid disease, because often the system EB scan can pick up the isotope and can give a false positive image. So if there is a multinodular goiter in the background, ultrasound scan can easily delineate from the thyroid or a parathyroid pathology. Now, scintigraphy, that's being done traditionally, and there are two ways of doing it. A planar image, as you can see it here, and a pinhole image. But now the scintigraphy has evolved a lot, and it is accompanied with a technetium 99 and in an advanced setup, single photon emission computed tomography can be obtained with an axial, sagittal and coronal views. And even in a more advanced setup, a 4D scan can be done, which I'm going to touch shortly. Scintigraphy, it has its own history. It has been experimented in the past by different imaging techniques, by different agents. In the initial days, thallium was one of the agents which was used along with the technetium, but thallium was extremely difficult to utilize in a setup, so it kind of became obsolete. Now, in most of the center across the globe, system EB or SPECT scan is the most commonest investigation which is conducted in order to investigate primary hyperparathyroid disease. We can go back and we can check that Coakley et al. In 1989, he reported the use of technetium EB for parathyroid localization, and that was the first group that they identified that the outcomes can be compared with the traditional one. Now, I've been talking about the system EB scan and the SPECT scan. So there are two phases in all of these investigations. Now, there's an early phase and there is a delayed phase. Now, the concept of the early phase is that all the glandular organs, which are your salivary glands, your parathyroid gland and the thyroid glands, they all take up the contrast, the dye, and they're all going to light up on the scan. That's fine, but there will be a washout after approximately a couple of hours where the technetium is only going to be retained in adenomatous parathyroid gland, and that's how it's going to light up. So in a normal day, a radiologist is going to conduct an investigation where they're going to get an early phase and another image after 2 hours, and that's how they're going to differentiate between a normal looking gland with an adenomatous parathyroid gland. But I also mentioned about dual tracer. Now this is not a new concept, but it's becoming more popular again by utilizing two different agents. As I said earlier, system EB scan, they're typically 20 minutes in the first set of imaging and a couple of hours, and after the washout one can identify an adenoma. Now all these scans are very good, and it has approximately around 85% sensitivity, and they can identify the adenoma for multi-gland disease, for especially in the four-gland disease where there is a parathyroid hyperplasia. These scans are not going to help you. As you can see in the first early image, there is a kind of an overall contrast taken up by all the glandular tissue there, but after a couple of hours it's clearly showing the adenoma in the neck. Problems with the dual phase is if an adenoma is rapidly washing out, that's not going to help, or sometimes in a multinodal goiter, the thyroid nodules, they have a delayed washout, so that will give a false positive picture as well. Now this is a new concept, and this is very interesting. Dual tracer, it's being done in my unit, and it's been recently published with an early results on a national level, and seems to be very promising. It's a radiological investigation which is combined with technetium along with the sodium iodide. So two tracers are utilized. And the concept here is that the technetium is taken up by thyroid and parathyroid, whereas the iodine is taken up only by thyroid. Now, with the help of artificial intelligence and some software management, there is a subtraction conducted on all these images, and manually and with the help of the software, this scan can identify the part of the neck which is taken up by the thyroid gland and is going to left aside the parathyroid glands. Now, the beauty of this scan is, as we discussed earlier, regarding the false positivity where there's a multinodular goiter. So here we can really deal with that as well. It's not being done in a lot of center. As far I have come across in UK and in Ireland, we are the only ones conducting this scan. There have been few centers in North America and in Germany, and 1 or 2 centers in France. They're also doing these kind of scans, and their sensitivity and specificity is extremely good, and it seems to be superior than the other investigations. So this is something which is the future. So these are the figures which I can quote from the other setups. In my setup, as we have just recently established, the numbers are not matching, but they are approximately the positive predictive value is around 80%. But the more we do it, the better we're going to get this facility up and running. Now, the problem with the dual tracer is that there is an increased radiation exposure. It takes more time, as you can imagine. There's more images are required, and there's more workload because there's a software involved, manual subtraction involved, and there are certain contraindications for this modality as well. For example, if someone had a recent CT scan or they're on some medication, they cannot undergo this scan. But in a specific cohort of patient, if this image can be done, it gives tremendous outcomes. Now, in order to minimize the radiation dose, in my unit we have came up with our own radiation protocol. So as you can see from this diagram, from this table, the allowance for the system EB is from 200 to 740 MBQ. We have capped up to 250, so we use the most desirable minimum dose, and we top up with the 20 MBQ of the iodide. So it's actually not too bad, and as I said, our early results are quite promising. Now, colon PET CT, it's a game changer. It's extremely useful investigation, but the problem with the colon PET CT is that it's not available in all of our unit. But in a very difficult parathyroid where all the previous images they have failed to identify, or you have a recurrence of primary hyperparathyroidism when you're planning to perform a redo parathyroidectomy. So as for the guideline, you should not embark on the surgery without having or utilizing all of your available radiological investigations. So here it is, colon PET CT. That's the guy which is going to help. Now, a bit algorithm about the radiological investigation. There is a flow chart, and all these guidelines and these flow charts and algorithm, they're here to help, but of course your local facility and what's available in your hospital and what are the guidelines, that plays a lot of role. We always aim for improving our setup, improving our unit, but we need to follow your local instructions as well. But if I simplify this, ultrasound scan, dual isotope subtraction scan, that's what we do it. We do the dual isotope subtraction scan for the localization of the parathyroid, and an ultrasound scan is done on the same day and that's done to identify if there is an associated thyroid problem. In a very difficult cases, we would go for a choline PET CT. Now, surgical intervention for primary hyperparathyroidism. Now, as you can see, there are loads of options available. The classical traditional teaching, and I guess in certain centers in North America, they're also doing it, especially in Tampa in Florida. Professor Norman, they're still doing bilateral gland exploration, and in their capable hands, I mean, the outcomes are very promising. But the problem with that is where you have one gland which is already being localized and it's an adenoma, and if you're going to search for the other glands and at least biopsy them, fair enough, that's fine. But the problem with this technique is that you are causing more problems with hypocalcemia and even transient or permanent hypoparathyroidism. And the more dreadful problem is that managing a permanent hypoparathyroidism, it's very, very challenging. And the patients are not going to like it. In a nice setup where a parathyroid adenoma is nicely identified on your given scan, the recommendations are to perform a minimally invasive parathyroidectomy. Now, that can be coupled with some video assistance, or that can be coupled with a radio guidance. In my unit, I do minimally invasive radio guided parathyroidectomy, and that's basically, I have identified a parathyroid adenoma on preoperative localization, and on the day of the surgery, patient comes in the morning and they get an injection of technetium. We don't get the image because that's already been done weeks before, but we utilize that injection of technetium as a marker, as a surrogate marker, which helped me to identify an adenoma. I'm going to discuss about the adjuncts in a while, but also sometimes I utilize the fluorescence guided parathyroidectomy if I'm performing a thyroidectomy and I wanted to make sure that the blood supply is preserved, so that can be done. And even in the identification of the parathyroid gland, ICG can be used as well. A couple of weeks ago, I did an ectopic parathyroidectomy, which was actually present in just sitting next to the aortic arch. So yeah, ectopic adenomas are extremely rare. If that can be achieved with a minimally invasive approach like VATS, fair enough, but sometimes even VATS, they are not really helpful. So one can imagine for a tiny little gland, the patient underwent sternotomy. So that's quite a, significant undertaking. Now, this is where the fun bit happens. This is where the magic is. So, the adjuncts. What makes a parathyroid surgery so successful? Here it is. That's the formula for that. So, once you have identified with the naked eye that is the adenoma, now I'm going to utilize some of my adjuncts. I'm going to send that to frozen section, and I have a really nice setup where I'll get the results in about 15 minutes, and the cytopathologist, she'll ring me and she'll let me know that, yeah, number one, it's a parathyroid gland, and number two, it is hypercellular. If it is a parathyroid gland, if it is not hypercellular, then probably there is something wrong. This is not an adenomatous gland. But before sending the gland to the lab, I will use that radio guidance which I mentioned earlier. The patient got injected technetium, low dose, in the morning. So I have a gamma probe in my theater, and after careful identification of the gland, and it's now removed, I will put it down in a gauze, in a Raytec, and with the help of a gamma probe, I will identify the background signal. For example, if it is 100 on a thyroid. Now, in order to make this Norman's 20% rule successful, I need at least 20 or above count on this excised parathyroid adenoma. If it is 20 or above, the numbers on the alleged parathyroid adenoma, then very likely this is adenomatous. Now this rule is coming from Professor Jim Norman, who is the master of the parathyroid surgery, who has performed so far above 50,000 parathyroid surgery. So that's basically his technique, and we have adopted this as well, and is a part of our adjunct. Also, we will perform after the excision of the adenoma PTHSA. There's so many protocols, but I utilize post-excision 5-minute blood, and I would require 50% or more drop in the PTH. So the patient at the time of induction, one of my team members will take a blood, and that will be our marker, and we are going to get post-excision 5-minute bloods, and that's going to help the success of the adenoma. And also sometimes, not always, I will use the ICG. So these are the adjuncts, and as you can see, preoperative localization, that helped a lot, and also going forward during the operation, these adjuncts, they're helping a lot as well, and that is making a surgery very successful, and that's how you're going to achieve more cure rates. Now, couple of new tools, new guys in the market. I can show you this fella, which is getting a bit popular in UK and Ireland. It's called PTI. It's a parathyroid detection system in vivo and ex vivo. It's basically, it has an accuracy of about 96% in confirming the parathyroid gland. It's NERAF technology, but what I personally like, and which hopefully I'm going to get it installed in May, it's a new fella, and that it works on natural fluorescence. There's no need of giving any agent like ICG. Now, it's a handheld device. It comes with a monitor. It comes with a little setup, and it has 3 functions. It can tell you if there's an adenoma. It can tell you if there's a normal gland, and it can identify the angiography, the blood supply of the gland as well. So it's not only for the localization of the adenoma, but also it's very helpful if one is performing thyroidectomy and wanting to preserve the blood supply of the parathyroid glands. So I had a very brief hands-on experience. I personally like it, so that's why I'm getting it, and we'll see how it goes. There are a few other agents as well, but I think Flowbeam and the PTI, that's probably approved, so we're going to work on that as well, and that is something which I can recommend. This is where the magic happened. That's where I work, Cork University Hospital, which is a center which is located in the south of the Republic of Ireland, and we proudly deal with highest volume of the endocrine cases. That includes parathyroids, adrenal, and thyroids. That's my team. Nothing is possible without a lovely team, and it's worth mentioning their name as well. These are my 2 mentors, Professor Jim Norman on the right, and that's where the Norman rule we have acquired. I have learned a lot from him personally in theater, and even spending time with him, he's always going to tell you all the pearls of wisdom regarding parathyroid surgery, and not the least Professor Paul Redmond on the left, who I'm currently working with, and he's an amazing mentor and a great teacher, and he has the same love for the parathyroid, what I can see in the other surgeons, those who have obsession with the parathyroids. These are my references. Thank you very much, and I'm happy to take any comments or any questions.